Hello everyone. We'll be discussing about lung carcinoma. Get to know how we will be proceeding with this lecture. We'll start with introduction, causes, etiological factors, metastatic sites, presentation, and pathological classification. Before beginning, we should know that CA lung is second most common carcinoma in United States behind prostate in men and breast in women. It is most common cause of cancer death in US and worldwide. In terms of socioeconomic status, lung carcinoma demonstrates a large disparity of all cancers, with the death rate in men 5 times higher for the least educated than the most educated. So this is the data which was being first published, which shows that in males, after prostate, lung constitutes major cause. Similarly, after breast in females, lung constitute the maximum majority of the cases. Coming to the estimated death, lung contributed maximum of around 21% in males with similar percentage distribution in females. Coming to the causes, the main risk factor is cigarette smoking. Voluntary or involuntary cigarette exposure accounts for nearly 80 to 90% of all the cases of lung carcinoma. Indoor radon exposure is the second leading cause. Other factors include exposure to occupational and environmental carcinogens such as asbestosis, arsenic, and polycyclic hydrocarbons. So coming to the similarly, what we have discussed, so tobacco smoking is one of the most important etiological factor for the CA lung. Followed by there is a chronic scarring of lung tissue in form of old tuberculosis, chronic interstitial fibrosis, old infarct. It may contribute to causation of carcinoma. Dietary factors also contributes like vitamin A deficiency. There could be certain molecular genetic aberrations, air pollution, which includes air particulates or radon, and industrial hazards, which include asbestosis, arsenic, chromium, uranium, nickel, vinyl chloride, or mustard gas. If the patient can present into the various symptoms to us if it is a localized disease like cough, which is seen in around 50 to 75% of lung cancer patients, followed by dyspnea in around 25%, hemoptysis in 25%. Some patients also complain with associated chest pain in 20% of patients. And few of them also can present with hoarseness, which could be due to the involvement of recurrent laryngeal nerve. So these are all the symptoms with which the patient can present to us. It could also be associated with in signs like finger clubbing, if there is unexplained weight loss or appetite loss, unexplained tiredness, chest heaviness, chest tightness. Now, what are the metastatic sites that are most commonly involved in CA lung? So the brain, which constitutes nearly 40% of the total chunk of cases in which there could be the brain metastasis seen, followed by adrenal glands, which constitute about 33 to 75%. So, the adrenals are the frequent site of metastasis. However, such metastases are only rarely symptomatic. Followed by liver, bones in around 30 to 50% of the cases, and lymph nodes could be regional or distant in around 20% of the cases. So, if the patient have a disease which is metastatic, how can they present with? They can present with like pain in back, chest, or extremity, which was suggestive of bone metastasis, headache, vomiting, visual field impairment, hemiparesis, seizures in case of a brain involvement. And once vascular or lymphatic invasion occurs, metastatic dissemination to distant site is common. Lung carcinoma has a peculiar feature of presentation along with the paraneoplastic syndromes. So, what are paraneoplastic syndrome? It is a disease or a symptom that is a consequence of cancer cells in a body, but is not attributable to local presence of tumor. Some of the common paraneoplastic syndromes which are being associated with CA lung are Cushing's syndrome, SIADH, hypercalcemia, Lambert-Eaton myasthenic syndrome, and hypertrophic osteoarthropathy. Coming to the pathological classification of CLR. So it could be either small cell or non-small cell. Small cell, it occurs mostly in smokers, but few patients and in few studies have also reported small cell carcinoma even in non-smoking patients. Coming to the non-small cell, which have a variety of further subclassification, but the most common out of them is adenocarcinoma, followed by squamous cell carcinoma. There could be few variants of large cell carcinoma, or some are associated with carcinoid syndrome. CA lung have a versatile presentation, and the treatment part, which we will discuss later, also depends largely on the molecular cytogenetics. So, if we see squamous cell carcinoma, it is always associated with smoking, and few chromosomal deletions are also being seen, like 3p, 9p, and 17p. There is sometimes loss of expression of RP tumor suppressor genes. An amplification of 5G5R1 gene is also being associated. If we come with small cell carcinoma, it is also strongly associated with smoking. And there is loss of function aberrations which involve TP53 and RPG, chromosome 3p deletions, and there is usually amplification of gene of mixed happening. Coming to adenocarcinoma, there is generally a gain of function mutation involving multiple genes encoding tyrosine kinase receptors like EGFR, AL, CROSS, MET, and RET. Sometimes there is mutation in KRAS gene as well. And coming to the lung carcinoma in non-smokers, which is more common in females and are usually adenocarcinomas. Most common mutation is EGFR, and TP53 mutations are also common. Sometimes there is an hereditary association seen with Lee-Fraumeni syndrome who inherited P53 mutations. And first degree relative have 2 to 3-fold increased risk. Thank you.